So, hello everyone. I think we are live. Can you please let me know in the chat box if my audio and video are good? Just waiting for your comments so that we can proceed. Okay. Okay. So, hello everyone. Welcome to this session on the Harrison 22nd updates on the chapter Seizures and Epilepsy. So, in this short session, we'll be focusing on the updates that have come in the 22nd edition of Harrison in comparison with the 21st edition, right? Let's get started. So we'll be focusing only on the updates. So one thing all of you have to note in the Harrison 22nd edition is that the classification of seizures listed in the page number 3409 is almost the same as in case of 21st edition, that is ILAE, which is the International League Against Epilepsy 2017 classification. But please understand that this classification as of now, that is in 2025, after the Harrison book got released, has further been updated. So I don't want you to follow this update is what I want to, not update. I don't want you to follow the 22nd edition Harrison classification is what I want to tell you. Okay. So you can clearly see that they have listed the 2017 classification, but no, that is not what you have to follow. It is the 2025 classification that you have to follow for your exams as well. Okay. So what I'll do is I'll just briefly tell you on the modifications that you have got to know in terms of the ILAE 2025. So you can see that in the Harrison's textbook, 22nd edition, they have given this particular uh, screenshot or this particular data on the classification of seizures. This is again the 2017 ILAE classification. You can see into focal onset, generalized onset, and unknown onset. So basically, Harrison 22nd edition, just like the 21st edition, gives you the basic version of the ILAE 2017 classification. And I hope that you remember about the more expanded version of the 2017 classification that I have taught you in my lectures in the DocTutorials app as well. This one that you're seeing on screen is the expanded version of ILAE 2017. But please understand that there are certain changes to this, and that is what I'll be focusing upon for the initial part of this discussion. Well, the change has come in light of this particular paper, that is the updated classification of the epileptic seizures that has come by International League Against Epilepsy and published in the Epilepsia as well, right? So I'll be just focusing on the key points that you have got to understand, not going to the entire details of the classification, but from an exam point of view, what are the key changes in the seizure classification from 2017 to 2025? The first point that you've got to understand is that the term onset has been removed from the main seizure classes. The term onset has been removed, which means if you look at Harrison 22nd edition, the basic ILAE 2017 classification, you can see here this is focal onset, generalized onset, unknown onset. So you no longer will be using this term onset is out. Okay, right. So that is the first point that you've got to understand. Now regarding the second point is a distinction is made between the classifiers and descriptors based on the taxonomic rule. So what essentially is this classifier and descriptor? Please have a look at this particular image that you are seeing on screen. Well, when you describe a seizure, you've got to use two parameters. One is classifier, the other is descriptor. So classifier is essentially classifying the seizures. What class of seizure is this? And this is defined based on, the seizure class, whether it is focal, generalized, unknown, or unclassified. And other than the seizure class, what else is incorporated? The level of consciousness. Remember, previously it was a descriptor, but now we have included level of consciousness as a classifier term, and also the seizure type as well. The seizure type as well, which means when you look at focal seizures, you can have focal seizure with preserved consciousness, focal seizure with impaired consciousness, and if a focal seizure evolves into a bilateral tonic-clonic seizure, you say that it is FBTC. Another point I want you to understand is that ILAE now prefers to use this term consciousness rather than awareness. If you look at the ILAE 2017 classification, the expanded version, you can see here, we preferred using terms like awareness there, but now no, it is not about awareness, it is more about consciousness. That is the term that ILAE is advising you to use. Okay, right. So next is about the descriptors. And what is a descriptor? Is again a further description of the semiological features of the seizure. That is a descriptor. Okay, right. Now, when you come to a descriptor, you can see that there is a basic version as well as expanded version, just like ILAE 2017, basic and expanded that I talked about. But the point that you have got to understand is that when you talk about the basic version, you are using terms like with observable manifestations and without observable manifestations. So if you remember ILAE 2017 classification, we use terms like motor onset, non-motor onset. You remember motor onset, non-motor onset. But what ILAE is telling right now is that rather than using such terms, you should be using terms like seizures with observable manifestations and without observable manifestation. Now, this is in light of maybe certain scenarios like absent seizures. Now, in absent seizures, as per ILAE 2017 classification, it is considered to be a non-motor seizure. But please understand that even absent seizure can also have subtle motor manifestations like eye blinking, which is an observable manifestation. Okay. At the same time, you can have certain seizures, wherein you might get some sort of a tingling sensation, a different sort of such non-observable, manifestations that is categorized as a separate one. So I hope you have got a clear understanding regarding this. Now you can also have an expanded version for the same. Now in the expanded version, what they are actually telling you is, look, in the ILA's 2017, the focus was on the primary event in the seizure, right? But when it comes to the expanded version, you've got to describe the entire sequence of the seizure phenomenon. That is what you've got to understand. The entire sequence has to be described in the expanded version. So let's come back to this. You can see here that the consciousness is used as a classifier instead of awareness. As I told you, that is what the ILAE prefers. And please understand that the consciousness is operationally defined by awareness and responsiveness, which means when you talk about consciousness as a term, there are two arms to this. One is awareness, the other is responsiveness. And awareness is what? The ability to recall. And what is responsiveness? It is the ability to respond. And ILAE defines consciousness based on both awareness and responsiveness. I hope I have given you a clear idea there. The next point that I've just told you, the motor versus non-motor dichotomy is replaced by observable versus non-observable manifestations. Again, I hope it is clear. Next, the chronological sequence of seizure semiology is used to describe seizures rather than relying on as the first sign is what the ILA actually tells you, which I've just again discussed with you. And another important point that you should understand is that the epileptic negative myoclonus is now recognized as a seizure type. It was not recognized as a seizure type in ILA 2017 classification, but is recognized right now. So these are 6 important points all of you have got to know in the update of the 2025 ILA classification. I hope I have given you a clear idea regarding this. Let us move forward. Now, when it comes to the page number 3411 in the new edition of Harrison, in the section of Lennox-Gastaut syndrome, that is under the umbrella of epilepsy syndromes. So that particular topic, not much of changes, but if you see under Lennox-Gastaut syndrome, they have just added one additional line in comparison to the 21st edition, and the addition I have highlighted. And what is that addition? We know that Lennox-Gastaut syndrome is not much of a pharmacoresponsive epilepsy. Definitely can become drug resistant, although some antiepileptics have been found to be decently beneficial. But you can see that the implanted neurostimulation devices are now being investigated for the treatment of seizures in LGS and other generalized epilepsies. So basically, they are talking about the neurostimulation devices like vagal nerve stimulation, which is VNS, the DBS, that is deep brain stimulation, and also the RNS, which is responsive neurostimulation. Okay, not repetitive nerve stimulation, but responsive, neurostimulation. Okay, so these are the neurostimulation devices that they are talking about. Then if you move to the page number 3412, I'm sure that many of you are familiar with that big table in Harrison on the epilepsy syndromes and their genetic associations. You remember this table, a gigantic table? Yes. So in the previous edition of Harrison as well, there were around 9 genes and their representation also being given in the 21st edition. But when it comes to 22nd edition, 2 other gene mutations they have described in this particular table. I have just taken the new addition alone. I have not put the entire table here, just the new addition alone. So I want you to focus on one gene, which is GRIN2A gene, which is encoding the NMDA receptor subunit GLU2N2A, and the clinical syndrome of this particular gene mutation can have a spectrum of manifestation, the phenotype of which can range from a benign childhood epilepsy with centrotemporal spikes to an epileptic aphasia syndromes like Landau-Kleffner syndrome, right? The next gene mutation that they are talking about is the CDKL5, which is the cyclin dependent kinase like 5, okay, which is a serine threonine kinase. And very, very important, this is linked to a CDKL5 deficiency disorder. And what is this particular disorder? It is a severe form of developmental encephalopathy, and this form is characterized by a very early onset seizures. This particular disorder is X-linked and affects females more than males. And a very important point has been added, that is genoxepalon, a recently approved anti-seizure drug, has been shown to significantly reduce CDD associated seizures. So these 2 gene mutations, the function, the clinical syndrome, they are all new additions in the Harrison 22nd edition, right? Okay. Now moving to page 3414. here is one another update again that I've highlighted is regarding post-stroke seizures. So what does 22nd edition tell you? So it says that acute post-stroke seizures, that is seizures occurring within the first 24 hours after an acute stroke, listen to me carefully, are more commonly associated with hemorrhagic strokes in comparison to ischemic strokes. And what did 21st edition tell you? Look at this screenshot. This I have taken from 21st edition. Look at this. Acute seizures occurring in the time of stroke, they are more commonly seen with embolic seizures rather than hemorrhagic or thrombotic stroke. So the incidence of this acute seizures, now what the latest edition says is that they are emphasizing that it is more common in hemorrhagic strokes than the umbrella of ischemic stroke. Another update that you should be noting. Coming to Harrison, page 3418, so wherein they have discussed about the EEG. So one recent advance in EEG has been updated in this particular page. And what is that update? So this update is regarding the high density EEG. This is there in the 22nd, but is not there in the 21st. So high density EEG, it actually provides a higher resolution. And why does it provide higher resolution? Obviously, it uses more number of electrodes. You can see that 256 scalp electrodes are being used as opposed to 21 electrodes used in the standard EEG recording. Very, very important. And what is being done with this particular data that you get from this high density EEG? So this is again analyzed by the EEG source imaging, ESI. So this permits visualization of the dipoles by mapping them into a three-dimensional model, and this is then co-registered on the brain MRI, which means a high-density EEG via multiple electrodes will allow better localization, and this is then reconstructed onto an MRI image, which then will show you the exact site of the seizure focus. So that is another update that is there in the 22nd edition of Harrison, right? Moving on to page number 3415, there are a few updates in this. Now, one update is regarding cannabidiol. Well, regarding cannabidiol, there was a mention in the previous edition of Harrison itself, and that was regarding the utility of this drug in syndromes like Dravet syndrome and Lennox-Gastaut syndrome. But in the 22nd edition of Harrison, they have added another indication as well. And what is that indication? Tuberous sclerosis is the addition in the 22nd edition of Harrison, right? And the 22nd edition of Harrison also adds two other anti-epileptics to this particular page. One is about fenfluramine, which did not feature as an anti-epileptic in the previous edition of Harrison. So this fenfluramine is an amphetamine derivative, and this is exerting its anti-seizure effect by inhibiting the serotonin reuptake and increasing the extracellular levels. So that is what you have got to know regarding fenfluramine as an anti-epileptic drug. Okay, right. So that is also clear. Next is about another anti-epileptic drugs, that is ganaxolone. We have just discussed about ganaxolone a while back. So ganaxolone is a synthetic analog of allopregnanolone and an allosteric modulator of GABA A receptors, and that is primarily used in what seizures I have just told you a while back on the cyclin dependent kinase like 5 deficiency disorder. Okay, so these are some other additional mentions in this particular page of Harrison, right? Okay, let's move forward. So coming to page number 3421, so they have listed these new anti-epileptics like fenfluramine. This did not feature in the previous edition of Harrison in this particular table. So the principal uses of fenfluramine in Dravet Lennox-Gastaut syndrome. They have mentioned. They have also mentioned regarding the typical dosing as well as the adverse effects as well. And so is the case with ganaxolone. They have mentioned the principal use. This is a potential question. This is used for CDKL5 deficiency disorder associated seizures. The neurologic and systemic adverse effects have also been mentioned. Okay, watch out for side effects like nasal congestion with the use of these medications. And yes, there is a mention of another anti-epileptic drug, which is cenobamate. So regarding cenobamate, what is the additional point that has been mentioned in the page number 3424 of Harrison? This is the highlighted part. So basically what I am trying to do is only the updates I am trying to highlight. I'm trying to make it very easy for you, just focusing on the updates alone. So cenobamate is a recently approved anti-seizure drug that has been shown to be significantly improving the seizure control in what sort of patients? Very important, patients with focal epilepsy who were not adequately treated with up to 3 medications. Okay, in such patients, cenobamate has been found to be very beneficial. Focal epilepsy. Okay, and you can see in the page number 3421 as well, cenobamate is featuring, and as I told you, principal use is in focal seizures. The neurologic and systemic adverse uh, effects with the drug interaction has also been mentioned in the page number 3421. Okay, right. Now, another point I want to mention is if you look at the Harrison page 3420, in this particular table on the selection of anti-seizure drug, a similar table was also there in the previous edition Harrison. But if you see, there are two new additions. One is cenobamate, and that I told you in case of focal seizures. And as an alternative in the atypical absence, myoclonic and atonic seizures, you have got fenfluramine. You please compare with the previous edition. You can clearly see that these two drugs, cenobamate as well as fenfluramine, did not feature in the table on 22nd edition, 21st edition of Harrison. It was not there, and that is what I've just shown you the screenshot right now. Okay, right. Now, in the section on status epilepticus, in page 3426, most of the content is same except for one line that is being added, and that is in the context of non-convulsive status epilepticus. So this is regarding the use of portable headband devices that provide a limited form of EEG. The advantage of this is that this can be rapidly applied without any skilled technicians, which actually helps you to identify non-convulsive status epilepticus in the acute care settings. Okay, that is what you have to know. Now, regarding another update, which is not a big update, but I'm just focusing on this because in one of the previous INI exams, a question related to this was asked. So the question at that time was regarding the frequency of a comorbidity, that is depression, that can be seen in patients with epilepsy. So at that time, the question was a factual question or on the percentage of patients having depression. Well, if you look at 21st edition of Harrison, it actually said depression occurs in 20% of patients. And the answer for that particular question was given as 20%. So not a big deal. It's just that in 22nd edition of Harrison, they have found that maybe the incidence of depression is slightly bigger. So now they have given a figure of 20 to 30. Only because a question related to this has been asked in the past. I'm just showing you this. That's it. Okay, right. And coming to the next point, well, regarding catamenial epilepsy, definitely there was a mention of catamenial epilepsy as a small subheading in the 21st edition of Harrison as well. But you've got certain additional info here. And what is that additional info in 22nd? It is the highlighted part. So they have said more specifically on the timing of the seizures or the vulnerability to develop seizures in patients with catamenial epilepsy. So vulnerability to seizures is typically highest just before and during menses and during ovulation due to the relatively high estrogen and low progesterone levels. So they have told specifically about the timing of catamenial epilepsy in the 22nd edition, right? Okay. Now another point is regarding the subheading of pregnancy. And see, with regards to pregnancy, a few changes. And one is just like the previous edition of Harrison, they have mentioned that the seizure frequency during pregnancy will remain unchanged in 50% women, increase in 30%, and decrease in 20, just like the previous edition of Harrison, no change. But regarding the mechanisms that are contributing to this change in seizure frequency, some of the previous mechanisms they have mentioned exactly the same, but they have just made a few additions. And one is mechanisms like increased renal blood flow, number one, increased volume of distribution. So that they have mentioned as additional points. So basically, that sort of points they have emphasized a bit more in the 22nd edition of Harrison. And another point that have been added is the highlighted part. They are stressing on the importance of seeing patients at frequent intervals during pregnancy and to monitor the antiepileptic drug serum levels. And another important point you've got to know is that the risk of seizure exacerbation increases when the serum levels decrease more than 35% from the pre-pregnancy levels. This was not mentioned in the 21st edition of Harrison, right? Okay, right. Now, another point I want to tell you is the closing part of this chapter of seizures and epilepsy. They have just added one more subheading. This is regarding special issues related to epilepsy in the elderly population. So what essentially they are telling you is that epilepsy, as you all know, will have a bimodal distribution based on the age, with the highest incidence occurring in very young patients and also in the elderly, right? And they are saying that the reason for this increased incidence with age is related to certain age related epileptogenic factors. And what are the age related epileptogenic factors? The most common is the stroke, very, very important, followed by neoplasms and dementia. So please understand, of late, neurodegenerative disorders resulting in dementia, they are also categorized as epileptogenic factors, right? And another important point, which was again not there in the previous edition, Harrison, is a specific mention of epilepsy in elderly having a preponderance for extratemporal location. So they are mostly in elderly rising from frontal lobe, parietal lobe, occipital lobe rather than the temporal lobe. So there is a preponderance of extratemporal epilepsy as well. Okay, so this is what these are the updates in the 22nd edition of Harrison, right? I hope I have made it easier for you on the 22nd edition Harrison updates on this particular chapter. Now, what others should be knowing is that for other subspecialties, we have already added the 22nd edition of Harrison updates in the app. So do not miss out on that. And for neurology, the other updates, that is updates from other chapters of neurology, will also soon be added to the app. Okay. So I hope you liked this sort of a concise presentation, and I hope that I've made your lives easier with such a session. We'll be taking sessions on other chapters as well. So I hope that is clear. Thank you so much, everyone, for joining, and stay tuned for more such information. Thank you.